Here's a clinical mystery. Consider a patient with clear breath sounds, but oxygen saturation is tanking, and upon drawing blood, it looks like chocolate. What gas caused this, and why is it still used to save lives? What is up, Peep Squad? Welcome back to Respiratory Masterclass, where I give you an in-depth look at a topic within respiratory therapy. Today's topic, inhaled nitric oxide. First, the concept. Nitric oxide is a selective pulmonary vasodilator. Unlike IV drugs that drop systemic blood pressure, iNO only works in the lungs. How? It relaxes vascular smooth muscle by increasing cGMP. This inhibits calcium entry into the cell, drops pulmonary vascular resistance, and offloads a failing right heart. Think of it as opening the express lane, but only for the lungs. So, what are the indications? The gold standard is PPHN, persistent pulmonary hypertension of the newborn. In the womb, fetal blood passes the lungs. If the pressure doesn't drop at birth, the blood continues to shunt right to left, and the neonate stays hypoxic, regardless of oxygen delivery. iNO breaks that cycle, dilates the pulmonary vessels, and stops the shunt. It is also used off-label in adults with severe ARDS, or right heart failure, as a rescue therapy to fix VQ mismatch when conventional ventilation isn't enough. Why is it safe? Because it has a half-life of seconds. The moment iNO crosses the capillary membrane and hits hemoglobin, it is deactivated. It does its job and vanishes. This requires a specialized delivery system that injects the gas into the inspiratory limb constantly to maintain a stable dose, usually starting at 20 parts per million. But iNO is high maintenance. If it mixes with oxygen in the circuit for too long, it creates nitrogen dioxide, a toxic gas that causes chemical pneumonitis. This requires constant monitoring to keep levels below 2 parts per million. And remember that chocolate blood? That is methemoglobinemia. Nitric oxide oxidizes the iron in hemoglobin. Rusted iron can't carry oxygen. If the patient is blue, but the PO2 on the ABG is high, check the methemoglobin levels. To manage this drug safely, use the mnemonic N.I.T.R.O, N.I.T.R.O. N, nitrogen dioxide, keep it low, strictly below 2 parts per million. I, indications, PPHN, the shunt breaker, or ARDS rescue. T, titrate, titrate slowly. R, rebound, never stop abruptly or the vessels will clamp down. O, oxidized hemoglobin, monitor for methemoglobin. Let's talk about that R for rebound. Because iNO shuts down the body's own production of vasodilators, if cut cold turkey, rebound pulmonary hypertension occurs. Wean it, 20 to 10 to 5 to 4 to 3 to 1. Give the body time to wake up. That is inhaled nitric oxide. Remember N.I.T.R.O, watch the methemoglobin, and save the right heart. Filed away. Class dismissed.